All right. Hi, I'm Stuart Swadron, and we're going to talk for the next few minutes about one of the cardinal presentations in emergency medicine, lower back pain. And of course, this is from the perspective of an emergency room physician. These are our objectives. We want to basically compile a list of the most important diagnoses that can kill people and maim people that we don't want to miss. Talk about some of the key history and physical findings that might lead us to work people up for those. A little bit about the indications for X-ray, MRI, the main diagnostic imaging modalities. And then just a little bit about what to do with the majority of these patients who have low risk, non-specific mechanical back pain, which is the great majority of these patients. So, this has got to be one of the most common. This is more common than just about everything. In fact, there are very few people that haven't had episodes of acute or subacute back pain at some point in their life. And it is one of the most common causes of physician visits in all venues. The way that we divide this up, I think you'll find it helpful, because the two first categories, posterior abdominal emergencies, basically anything back here that can present as lower back pain, and cord compression, those are the serious things. And those are comprising most of the, you can't really miss those things as an ER doctor diagnoses. Whereas the bulk of these fall under different categories under musculoskeletal, and they're generally going home. And that's why I've sort of put them in a different color, because they're a little less serious usually. And again, within those categories, those broad categories, we have the kind of don't miss diagnoses that are most important not to miss at the top, AAA, abdominal aneurysm and ectopic pregnancy. But the other diagnoses here, as you can see, they can be quite morbid, and you can die of them too. And so we need to sort of systematically think about the GU causes, of which there are quite a few, and then the GI causes. So the second big category is cord compression. And these are, on some level, they're all kind of the same. You've got a patient in whom you're concerned about compression on the cord, most often identified by some concerning neurological symptom or sign, and whether or not it happens to be from an abscess or a tumor or hematoma may not be that critical. It's the fact that you've got some neurologic, again, signs and symptoms that tip you off that there could be some compression here. Now, cauda equina is not, strictly speaking, cord compression, as we all remember from med school. It's actually the lower motor neuron fibers after the cord ends, but it's the same thing. You've got hard neuro findings that can't be ignored that need urgent intervention. And then when we get to the more, so to speak, benign diagnoses, not that I would tell patients that they're benign. People, lose their jobs over these diagnoses, and I know that they can be quite debilitating. But generally, these will be going home from the ER, and these are degenerative disc disease, which we'll show a few pictures of, and then seropositive arthritis, so serious stuff: lupus, rheumatoid arthritis, spondylolisthesis, which is a mechanical problem of movement of the spine, which I'll show you, subluxation really, and disc herniation with nerve impingement, which is basically goes along with degenerative disc disease, but it actually is more specific in terms of telling you what happens after the discs degenerate, how the actual compression occurs. So those are two parts of the same thing. Now, history red flags, I think we all have to know well. All right, so the very young, you're concerned. They don't usually come in with back pain. And then older people, when they come in with a new onset of back pain, the risk of something bad is so much higher that you have to take them more seriously. Trauma of any sort is important. It's very, 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 very important. And in terms of systemic symptoms, you're really focused on people that have cancer and TB, and they'll have systemic symptoms. They'll be losing weight, night sweats. Anyone who has worse pain at night and at rest, that's a red flag. Neurologic deficits that are anything more than just, a single nerve root. So sciatica usually is then, as it progresses, accompanied by some neurologic signs. They might have some numbness, they might have some weakness. And that's generally not a cause for great alarm if it's a fairly stable situation. It's when multiple nerve roots are involved. It's when you have a progressive neurologic weakness or any signs of bowel and bladder dysfunction that you start to get really concerned. Obviously, you have a history of cancer, TB, circulating bacteria for any reason, like indwelling catheters or IVDA. That's also all very concerning, and it changes the calculus. So those are the main history red flags. The examination red flags are here, okay, and there's a little overlap between the history. Obviously, they have a fever, that's really important. Pulse deficits and pulsatile mass have to do with AAA, which is incredibly important to rule out. Any findings of decreased sensation around the anus or rectal tone, depending on which one you do, is very concerning. Any symptoms and signs that are bilateral are very concerning because, again, the typical sciatica that you get from mechanical back pain and compression on nerve roots is not on both sides. And once it's on both sides, you really have to think about the cord that's central, that's in between the roots on both sides. And so that automatically makes you more concerned. I mentioned here L4, L5, S1 specifically because in your exam for lower back pain, in addition to all these red flags that you're going to want to have documented, you really need to draw a little stick figure and show that the L4, L5, S1 strength and reflexes are symmetrical. And that you don't have findings there. It's sensory examination, to be completely honest, if you look at what the neurosurgeons do, takes a secondary role. Motor examination and the bowel and bladder are the critical first steps, and you really should, again, systematically check L4, L5, and S1. I do that actually just by having them do a squat for L4. L5, I have them stand on their heels, and S1, I have them stand on their tiptoes. So that's actually something you can do at the bedside fairly easily. Anyone who's specifically complaining of midline back pain, it's right here, doctor, that's concerning. That makes you think about metastatic or focal infection. Also, remember that low back pain is low back pain. When the back pain starts to creep up between the clavicles, that's way more serious. It's much more likely to be something bad like cancer or dissection. So low back pain is low back pain. It's not upper back pain. So in terms of the workup, I think this is a very helpful slide actually because it gives you kind of the key things in these various categories. When it comes to the posterior abdominal emergencies, you can really quickly rule these things out. You got to do a good abdominal exam. That covers a lot of the things that we were talking about: the API, the pancreatitis, the pelvic is important for the gynecologic disorders. Pulses, easy to do. Ultrasound to check for a AAA, easy to do. We do that very quickly. UA picks up a couple of those diagnoses. ICON is critical on any woman. So that's definitely a big chunk of the badness there. Core compression syndromes is just really about that neuro exam that we discussed. I mean, you get a motor exam of the lower extremity, you got your focus on the bowel and bladder exam, and then that's really what you got. And if you don't have any of those, you're probably dealing with musculoskeletal pain that's going to go home. One of the questions that does come up, though, is that if it's a new onset of back pain, again, in someone that's over 50 or a real young person, we often image them because they do have a higher incidence of these things, and often just a simple x-ray will pick them up. So what I've done here is I've just written a list of the important generally accepted indications for getting an x-ray. That elderly number of over 70 is a bit generous. I think most people would say 55 or so, most organizations. There's all those other things that we mentioned there. If it's going on forever, they have systemic symptoms, any of the red flags that don't require an MRI might be reasonable to do an x-ray on. MRI, on the other hand, you don't do x-rays and mess around with simple x-rays if they've got an acute evolving neurologic lesion. In that case, they need an MRI because you want to know right away about neurosurgical intervention. And so there is a little bit of a split point there. When patients have progressive neurologic dysfunction and that you think it's cord compression going on, really you're going towards MRI and neurosurgical consult quickly. When they don't have any of those severe progressive neurologic signs, they might be appropriate for x-ray. And so we kind of mentioned these things already. Now, just a couple of other images just to reinforce what we've talked about. We're not going to cover anything new. I just want to make sure that we've really fleshed out all those red hot, the worst diagnoses. So for posterior abdominal, you must do something to assess the aorta in any patient who's got hypertension and who's older, maybe 50 and up. And that's very simply done by measuring the outer diameter of the aorta. And you can see there that there's a huge clot there and then a small lumen, and that's all AAA. And so most of you have seen that at some point. This is a positive FAST. So a simple ultrasound to look at the aorta, and in a female to look for free fluid, which could be from a ruptured ectopic or other emergency, pelvic emergency, is really, I think, critical and can be done very quickly at the bedside. That second set, cord compression, just a few images I wanted to show you there that just put a little more detail to what we've discussed. Quite frankly, it doesn't matter whether you're dealing with osteomyelitis of the spine, discitis of the spine, or a spinal epidural abscess. I mean, the spinal epidural abscess is the one that sort of the poster child for the thing that we don't want to miss. But you don't want to miss these other two things either. And frankly, even though they're all different, they're all the same in the way they present. They're very similar, right? You've got back pain. You've got some infectious signs, right? Maybe it's focal tenderness. Maybe it's a fever. Maybe it's a very high white count. If there is one lab test that you need to know, it's ESR, because the ESR, the erythrocyte sedimentation rate, is rarely not elevated in these bad infections of the spine. Osteomyelitis on the MRI looks slightly different than discitis, which, by the way, is a bacterial process. It's caused by Staph aureus. These are usually in people that have circulating bacteria, like they're IV drug users, they have indwelling catheters. Diabetes also puts them at risk on top of that. Spinal epidural abscess, again, the same rules apply here. You can actually see it's hard for me to see from my angle, but you can actually see that it's impinging into the cord, that there's an abscess there. And again, the screening test of ESR, if you're not sure, should pick most of those up. Now, it goes without saying that if they have neurologic findings already, you're not waiting for anything. You're calling a neurosurgeon, you're getting an MRI. I'm talking about when you don't have neurologic findings, but you still have these risk factors for infection. That's when you need to start thinking about getting these picking these up before they start to actually have neurologic symptoms. And so it's important to screen with ESR for these before they have actual neurologic deficits. Now, in this one, fracture with impingement is another critically important one. Any of the older ladies with osteoporosis, any man who falls off a ladder, that's coming in with back pain, or fell off a ladder even a week ago and has pain, this is kind of what you're looking for. You're looking for a fracture. And in this case, it's not a plain X-ray, it's a recon. But you can see that this vertebra is completely smashed down, and more importantly, you can see that it's pushed its posterior components into the spinal canal that can cause compression. So that's a very serious situation, and the neurosurgeon has to be consulted. Any loss of height anteriorly in the typical compression fracture, you won't lose more than, let's say, about half of this anterior distance. If you lost more than half of that anterior distance there, that length, as you can see you have here, you instantly qualify for further imaging and ruling out cord compression syndrome. And the same goes, not the same goes, but for the posterior aspect of the spine, any loss of height is indicative of a possible spinal cord compression. So the vast majority of little old ladies that have osteoporosis that have compression fractures where there's just a bit of loss of the anterior height, that's okay, and they can end up being discharged. But anytime you've got more than just that little bit of a wedge, you have to look into it with CT, MRI imaging, depending on if they've got deficits, and neurosurgical consultation. So just to finish off, I just want to say a few things about the more, so to speak, benign diagnosis, the MSK diagnosis, because again, just like in any other subject, they do tend to ask a few questions about this on exams, and the patients, they want to know a little bit more other than, oh, it's benign, go home. They really need some more guidance, and there's some specific diagnoses within this that I want you to know. So nonspecific back pain, and you've got many different names. Lumbago, that's one of my favorite names for it. I got a little lumbago. You can generally observe those patients for several weeks before you have to go nuts, and their primary care provider can do further tests if they continue to be symptomatic. And basically, I alluded to this before, but the whole process, I didn't describe it very well in the first slide. The whole process basically has to do with discs that dehydrate over time as you get older, and then imbalances that happen as the disc dehydrate. There becomes asymmetry and imbalance of the way that the two vertebrae are sitting on top of one another. And that basically, as it causes a pinching of the nerves as they come through the middle of the two vertebrae, through the foramina. So basically, dehydrated disc leads to it kind of collapsing, uneven forces between the two vertebrae, and then one side, usually more than the other, getting the nerve pinched. This is all a fairly benign situation unless you actually have herniation directly into the cord, and that's why we talk about bilateral symptoms as being such a concern. The treatment for this, if I could give one word, would be activity, right? I mean, that's the biggest change in paradigm over the past 10, 20 years is that, you've got to keep going. If you immobilize, you'll get worse on these. You should be aware that NSAIDs aren't for everyone. They're not for patients with renal failure and bad diabetes and other things that can damage their kidneys. So we tend to use acetaminophen on older people when we can. Opioids, judicious, short term. We got to be very concerned about overuse of these. Just a few things on the x-ray that I wanted to point out, because we did say that if the patient's over 55 with a new onset of back pain, I generally image them because there's a higher yield. And the things that you're looking for, just quickly, is you want to make sure that the pedicles, and they're kind of, they call them owl's eyes, are all intact, because if one of these is eroded or missing, it's a very important sign of metastatic disease from, say, breast cancer, prostate cancer. So that's actually pretty common. The other thing that you should look for is the psoas shadows. You see there's a line here and there's a line here. One of the things that we didn't specifically mention were that if you are sick with back pain and you have a fever, maybe even you're a little bit shocky with this, it could be a psoas abscess or a psoas hematoma. And you might pick those up actually just on plain film by a loss of the psoas shadows. But often it takes a CT and a degree of suspicion. Moving on to the lateral view, there's less to know about the lateral view, but it's mostly just about making sure that these are lining up and that there's a similar space in between them all. Not rocket science really, just more about alignment and distances. And this is just another demonstration of how those uneven pressures start out by a dehydrating disc. This is an example of degenerative disc disease where you lose that height, you lose the space between L5 and S1, very, very common things. Spondylosis, they might ask you. It's kind of a vague general term, but it generally has to do with degenerative disc disease. You'll see osteophyte formation, which I'll point out right here. Lipping, you can see thickening, sclerotic thickening of the bone in the joint spaces. These are all signs of osteoarthritis, basically. You can see bony cysts as well. In a severe form, it can be very difficult to interpret these x-rays, and that's often why we have to do more advanced imaging if we're concerned, for example, with C-spine trauma in an older person. This kind of thing can be too hard to read. Spondylolisthesis is actually when one vertebra slips over another, and that's actually quite common at the L5, S1 level, as you can see here. And actually, it sounds like it would be the worst thing in the world. Like, it sounds like you'd become paralyzed right away, but in fact, it's actually a fairly subacute to chronic process that starts off by a little defect here, what they call a pars defect. And then there's slippage that goes forward, and it can actually be very subtle and gradual, and they can present just with pretty nonspecific back pain in both adults and children. And so this is something that's worth noting, but just because you see that doesn't mean that you need to have, you need to do a ton more tests. It might just be a matter of, if their neuroexam is normal, noting it and following it up and watching how it evolves. Which is kind of surprising, but that's the way it is. DISH, diffuse idiopathic skeletal hyperostosis. Again, it's just one of those words that comes up all the time on exams, and you might see it. And another word for that is bamboo spine. And so some of the inflammatory diseases, the chronic, like HLE, B27, spondyloarthropathies, ankylosing spondylitis can look a little bit like this. Some type of an immune process that basically causes the whole spine to connect into one big piece, and that's called DISH, associated with seronegative spondyloarthropathies and other inflammatory diseases. This is just another example of a spine that's kind of infused together. In this case, it's from ankylosing spondylitis, which is more common in men. They have trouble, remember, bending over. They might give you that hint that they can't bend over, but this is an outpatient diagnosis as well. Spinal stenosis is another outpatient diagnosis in general, but I just wanted to mention it to you because it's so common on a test, and when you miss it clinically, it's kind of a bummer. Basically, what you got to remember is that claudication is when you have pain in your legs because you got bad circulation, right? So you stop, you rest, the circulation gets reestablished and you feel better, and you can only walk a small distance before you get that cramping pain. But when people tell you they have claudication, where they have pain and they have to stop walking, it's usually when they're walking on level or when they're walking uphill because there's exertion. In spinal stenosis, which is basically just a thinning of the canal as a result of all this arthritis and degenerative disease that people get as they get older, they report this pain when they're actually walking downhill. And so when they'll give you that question where the person is older and they've got DJD, arthritis, and they're having pain when they walk downhill, certainly think about this spinal stenosis. And again, making the diagnosis and referring them as an outpatient is usually all that's required. So that's low back pain in about 20 minutes, and hopefully that's helpful for you. Thank you very much.